This is placeholder media that you'll see if you add a layout to
It's
an
time
empty
for the
scene.
View in Your Mirror
You can go ahead
podcast.
and
I'm
delete
Katie.
it.
Lisa, Lisa, Lisa.
Good morning, Katie.
You are post-birthday, Lisa.
I am post-birthday. I am. I had a wonderful
Basking.
birthday.
You're basking in the glow of a big number.
It's a big number, Katie, but happy to be here.
That's exactly the right attitude. I took you to lunch. You could pick anywhere you want. Where did we go?
We went to Rustica, Katie. I didn't want to do that fancy thing. I wanted to just do what you and I love. And I
Well-
had my favorite sandwich, and you got me a cookie and my iced tea. I could have been happier, Katie.
And of course, anyone can pick to go to Rustica for any special event or just every good old day-to-day. You just need a little pick-me-up. We did have a cookie, didn't we?
We did have a cookie, Katie, and they have new cookies.
It's pistachio.
Everybody, they have new cookies that I like just as well as the other one. In fact, you have to buy them in packets of 4, and I did, and I ate one whole package. When you went to pay for the cookies, you made a friend, which is
Of course.
always what happens.
Yes, I did. Our new friend from Miami.
Yes, right. So
Yeah.
you came back with a friend.
I did. And her daughter was presenting at Edina Art Fair. So, the world is just fun. But listen, okay, Rustica, we got to talk about. They're uncomplicated, they're real, and they have 4 locations: Minneapolis Uptown, downtown Minneapolis, Edina, and Wayzata. So there's no excuse not to go there. They're open every day, and rusticabakery.com. So there. Now, hey, we have been listening to the people who love us and listen to us, and we like feedback and we get it all the time. But to the women who keep telling us to get to the good stuff faster, we're listening, right?
We are, Katie, and oh my goodness. I am so excited about this podcast. I've told a lot of people that we were recording today, which I don't normally do.
So, interesting.
So I have a big question for you, Katie. Do you know what the word beshert means?
I do, because you taught me, right? Meant
Yeah.
to be. And our guest, I feel like, was a case of beshert.
It was. It was definitely a case of beshert. And, you worked hard to get us where we are today recording. And I am so excited about that.
Well, I will tell you, I was at the world's largest menopause party in Las Vegas, and I took my sister, and my sister is she's a little more shy than I am, right? She did not want to sit in the front. I'm like trying to pull us into the front. Well, there was a break. And then at that point, I said, come on, we're moving up. And so we ended up moving up into basically the front row. And I sat
course you
down
did.
next to Dr. Mindy, who we started a conversation, and voila, here we are today. So I consider it to be one of the best meetings I've ever had, because this woman is really someone special and everyone needs to know what she has to say. So let me tell you about her. For almost 3 decades, Dr. Mindy Goldman has been a clinical professor in OBGYN at the University of California, San Francisco, where she founded the Gynecology Center for Cancer Survivors and At-Risk Women. She is a nationally recognized expert in menopause care, has authored national guidelines for ACOG, and chaired the menopause and sexual health panels for the National Comprehensive Cancer Network. She is now the chief clinical officer at MIDI Health, who we love, and she came to it through a personal journey and a foundation she built in honor of someone she loved. Dr. Mindy Goldman, thank you so much for being with us. We are thrilled to have you and your expertise and your willingness to be with us. Thank you.
Well, thank you for having me, and I'm really excited to talk to you.
So most physicians land in a specialty through training and opportunity, right?
Agreed.
You landed in menopause medicine through something far more personal.
Yes, and I would say specifically menopause medicine as it relates to cancer survivorship. That is very much my personal story and how I landed here. I do think that menopause medicine in general is very much a part of who I am as an OBGYN, but the narrow niche that I helped develop is very personal.
Yes, it is. So do you want to tell us a little bit about your story of Marina?
Sure. Let me start earlier, which is I decided to go into medicine, from the time I was 10 years old, actually, when I had an appendectomy, and a friend of the family did my surgery and took me into the OR awake and let me look around. And I thought, gosh, if I live, I want to be a doctor. So years later, I become a doctor. I was one of these people that really liked all specialties, but there was something that really drew me to OBGYN. I liked the medicine aspect, I liked the surgical aspect, I liked being able to help women. And so I became an OB-GYN, and I ended up doing my training at a wonderful institution, the University of California, San Francisco, UCSF, and that is a very academic place. And I learned that I liked that academic environment, and I wanted to stay in that. And I was lucky enough to get asked to join the faculty there after I finished my training. And so I joined the faculty as a general OBGYN, and I found some of the things about me were that I love to teach. And I love that whole environment. I love teaching medical students, residents, and I saw my career as developing into either directing our medical student education or directing our residency program. And I think the department was trying to groom me that way. And then my life really took a turn when my dearest friend, Marina, her Hawaiian name was Uilani, which means heavenly beautiful, I believe.
Oh,
I think. Actually, I'm not. It's something like heavenly beautiful. When she got sick. So I met her I was doing a sub internship at a hospital where she was doing her residency. She was a family practice physician. And we both ended up in the Bay Area. She was my dearest friend, and she ended up getting diagnosed with breast cancer at a very young age. She had not yet had her first mammogram. And I am thankful now that I didn't know as much about breast cancer then, that I knew it was bad, but I didn't really understand how bad it was. And I got very involved in her care. I would go to a support group with her partner. She ended up dying within a year and a half of diagnosis.
Mm.
And a few things that happened during the course of her illness. One is she, like myself, were Western trained physicians, and UCSF had what's called the Osher Center for Integrative Health. And she started being seen there and started doing some integrative things to improve her quality of life. Things like acupuncture, particularly, and energy work. And at the time, because that was part of UCSF, some of it was covered by insurance. But as she did what was there and then sought care outside of UC, we realized that those weren't treatments that were typically covered by insurance. And so while she was sick, we had already came up with the idea of let's start a nonprofit together to help breast cancer patients get complementary and integrative support to improve their quality of life. Not to treat their disease, but all the things that really helped her during her treatment. It gave her the energy to work out in the gym. And we know exercise is so important when you're going through cancer treatments. When she passed, we decided to start that nonprofit in her memory, her partner and I. Before she died, I actually went on leave from my job to help take care of her at home, where she did pass away with her parents, her partner, myself. And it was an incredibly traumatic time to watch your dearest friend pass away. And I was also staying down there, so was really involved in helping her out during that process. It was just incredibly emotional and incredibly difficult and hard. And when I came back to work, so I came back to work about 3 months later, a few things happened. One was before I went back to work, it was a real difficult time in life, and I was seeing a grief therapist to help me out. And I can tell you the moment when it came to me and where I was leaving a therapy appointment. I was at a red light. I was turning onto a street when it came to me that you're supposed to shift your career and do something related to this. I didn't know what it was, but that something just came to me about you need to learn from what you just went through and change what you do professionally and personally, because we had just thought of let's really focus our energy in developing this nonprofit. And so when I came back to work, I told my department I would love to work in our breast care center, maybe seeing patients there a day a week, learning from breast oncologists and breast surgeons more about breast cancer care, because I'd like to be able to focus my OBGYN knowledge in helping cancer survivors. And they thought that was a great idea, and they actually negotiated with the breast care center. And at the time, the breast care center was actually having problems getting new patients into the center because luckily most people were living with breast cancer. So they were looking for someone to do what's called follow-up, seeing healthy breast patients, make sure they're doing well, and just make sure they don't have recurrence of disease. And all of a sudden, this OBGYN comes along saying, hey, I'd love to work there and learn from you. And so I ended up, our departments negotiated, and they said, we're going to put you there 50% time. So that meant all the things that I was thinking about doing in terms of medical student education, or maybe someday being a residency director, got put aside because I got put half my time in the breast care center. I ended up giving up obstetrics, which I had only finished my training this was in 2001, and I had finished my training in 93, so early 2001. So I hadn't been practicing that long. And what started happening was while I was in the breast care center, people would, knowing that I'm an OBGYN, would come up to me and say, hey, this person was thrown into menopause from chemotherapy. Can you give us a sense of what we should do? Or this person is having pain or bleeding on a breast cancer drug like tamoxifen. What should I do? Or this person's having sexual dysfunction, or they need contraception. And I start looking in the literature and am shocked that there is almost nothing there. So fast forward 25 years now, I feel very lucky to have helped develop a field that I think of as bridging breast oncology and gynecology, and really focused on women's health issues related to breast cancer treatment. As that has evolved, I have expanded into other cancers, because if you were thrown into menopause from cancer treatment, from chemotherapy, let's say, menopause is menopause. Treatment options may differ greatly, but menopause itself is the same. And so I've expanded to cancer survivorship as a whole. I feel very lucky that I've been able to do research in the field. UCSF supported me in allowing me to develop this clinical program. As I started doing more, I started publishing. That got my name out there. I got asked by the American College of OB/GYN to write their guidelines, focus on the gynecologic implications of breast cancer. I got asked to be on the survivorship panel for the National Comprehensive Cancer Network that helps provide guidelines on survivorship issues for practicing oncologists nationally. I chaired their menopause panel and co-chaired their sexual functioning panel, and really got to have a career that I never thought I would have based on this personal experience. And I'm sure we will get to it, but that has even led me to MIDI. Developed everything I could at UCSF. I am now I retired from there in 22, but I am still part-time, helping develop a fellowship in this area, trying to train other faculty so that this can continue. But I started realizing I've done a few things in tech, advising a couple small startups that are focused in the survivorship space. And one was a menopause startup that didn't make it, but it's when I had the aha of that was a telehealth startup where people paid out of pocket. And I didn't really want to take care of people that were just wealthy and doing this out of pocket. I wanted to try and have a bigger impact, but that's when I had the aha moment of you could do this care over telehealth. And this was pre-pandemic. And at the time, I was also starting to feel like I can't keep up with the demand at UC. More and more patients want to get in. I am training more people, but I realized that this should be a specialty in and of itself, and we should be expanding this care broadly. And I wanted to scale this. And when the founders of MIDI came to me, they came to me because they talked to the leadership that had been involved in this company that failed. And when they came to me, they also said, not only do we think menopause is a huge gap in care, but we think managing menopause for survivorship is a really big gap in care and is a huge unmet need. And I felt like, oh my gosh, this is what I've been saying all along. And so the timing was right that I could, it wasn't quite right. I had to finish. You can't just say, hey, here's 2 weeks notice. I've been in practice for almost 30 years. So after a year, I joined MIDI full-time, where I'm the chief clinical officer, but I really joined with the intent to scale survivorship care, which how lucky am I that I'm getting to do this?
Incredible. Well, you're lucky, but you have also done such work that puts you in the position to be able to be this. And I was happy to hear you were talking about that you have built programs within the teaching modalities.
Mindy, it's awesome. Everything you're saying is awesome. And I'm listening to you. Everything you have done is getting you to where you are now, right? And
Exactly.
so if you wouldn't have had all of that in the beginning, you wouldn't be where you are now and be so passionate about what you want to do.
Yeah. Yeah.
And
I really do feel lucky. Like,
one thing I can say in listening to you, and I'm in a very different space than you, I've been doing what I've been doing for so long, and I'm very passionate about what I do, and it's for women to make them a better version of themselves. And a lot of people say, well, when are you going to stop working? And I go, I don't even think about that,
yeah.
because
Thank,
what makes me who I am today and who I will be in the future is what I'm doing professionally. And this podcast that Katie and I have done for 6 years, and now we're getting into a space that we want to be in for our podcast. And I'm a better version of myself every day. And I look at so many of my clients that are very successful women doing incredible things all over the world. But the ones I see that are passionate about what they do are doing it better, and they're
yeah.
happier, and they're in a better space. And I
Yeah.
see that with you. So
Yeah.
good for you, because we need you. We need people like you. And, from personal experience of helping my sister, who's a 2-time breast cancer survivor, I mean, the struggles that she has had and she is having and all of that, I see it with my own eyes. And we need people like you.
Thank you.
How do we help women understand their whole health journey? The statistic says that 1 in 8 women will get breast cancer. Now, that's not talking about the other cancers and the downline to that. Okay, and that number certainly drives a lot of fear. And the fear around hormone therapy, which we really, really want to talk about. But 100% of women go through menopause if they're lucky to live to that point, right? So it's not a risk factor, not a maybe, but they do. So how has the condition that's universally been so dramatically underserved, how do we now make sure that we continue to advance this forward? I mean, the fear to me is, the health initiative that came about in 2001, how do we make sure that stuff like that never happens again?
That's
I
a
know
lot.
it's a lot.
That's a lot to unpack. Well, let's talk a little bit about breast cancer in general, breast cancer and hormones, where the fear came about, where we were in the
Yes.
days of the Women's Health Initiative, and where we have gotten to now. Because I do want your listeners to hear that we are in a very different place now than we were 25 years ago, and conversations are changing. And conversations that we never thought we would even have with women, things like, I had breast cancer, are hormones always off the table for me? No one would even have that conversation of even considering systemic hormones in someone who previously had breast cancer. And at least we're starting to have those conversations now. So I want to start with a really hopeful space that people can hear.
Yes, perfect.
Breast cancer is an incredibly common disease. It, as you mentioned, the lifetime risk is about 13%, or about 1 in 8 in general. Women will get breast cancer if they live to be 85. So our risk continues to go up until about age 85 when it stabilizes. There are a number of risk factors for breast cancer. Being a woman is one. We can't change that. We do see breast cancer more commonly diagnosed as we age. As I said, the risk continues to go up. So there has always been a thought that hormones could be related to breast cancer, because you see breast cancer commonly happen when women are in the menopausal years. And that leads a little bit to discussions about the whole Women's Health Initiative. But before that, I would say we are learning a lot more about risk factors for breast cancer. We are learning that there are things that people can do. Alcohol is a risk factor for breast cancer. If you minimize alcohol and you get regular exercise, specific amounts, 150 minutes a week, divided times, interval cardio, there is evidence that may prevent breast cancer. Like, how interesting is that? Is as important as when people take medicines to prevent a cancer, that there are things that people can do. A lot of interesting studies that came out of the American Society of Clinical Oncology just last week about GLP-1s and their potential role in preventing cancers like breast and colon cancer and others. That's a whole other really fascinating area that we're just starting to understand. But if you go back to the Women's Health Initiative, which I think by this time a lot of people have at least heard of it, but just to briefly go through, the Women's Health Initiative was the largest NIH-sponsored trial, and it was designed to see whether the use of hormones prevented heart disease, which is the #1 cause of death for both men and women. And the reason why they did that was prior to the Women's Health Initiative, there were studies that showed that women who took hormones seemed to have a lower risk of heart disease. So that was the impetus behind studying the Women's Health Initiative, to see if you gave healthy women hormones, did it prevent heart disease, and was it associated with any risk of other diseases? And as many of your listeners have probably heard, and you all know by now, there was a lot of bad press in 2002 when one arm of the study showed, and that arm of the study included women who took a specific form of estrogen and what's called the synthetic progestin. And that arm of the trial was stopped short with the finding that it did not prevent heart disease, and it surpassed the threshold for breast cancer. Press totally takes off with the results. That event has influenced care of women for the past 25 years. That is when women started worrying hormones must cause breast cancer. That is when the medical community started using the word cause breast cancer. We have always known that hormones are the most effective treatment for menopause, and given that hormones were then thought to be off the table because they might cause breast cancer, it also led to why train people in menopause. And it led to where we are today, of this huge gap in care where women have just been told, just deal with the symptoms of menopause, because the most effective treatment is dangerous and is going to potentially cause you to get a common disease like breast cancer that 1 out of 8 women get. So that's how we got to where we are today. There were so much behind the Women's Health Initiative. They never publicized that When that arm of the study was stopped, the arm of the study that included women on estrogen only. So if you've had a hysterectomy and you take hormones, you tend to take estrogen only. Estrogen is the component of hormones that makes you feel good, but you need some form of a progestogen to protect the lining of the uterus and prevent uterine cancer. If you don't have a uterus, you don't need the progestogen component. In the estrogen-only arm of the study, they actually found a lower risk of breast cancer. That never got publicized, and long-term follow-up of that arm of the study showed, compared to the placebo group, statistically lower risk of getting or dying of breast cancer. And that was published in 2020, and that helped us get to the point where we are today of understanding that the component of hormones, if any, that has negative effects on the breast is likely the progestogen component and not estrogen. And back in the Women's Health Initiative days, we tended to use very different progestogens. We use these synthetic progestins that are very good for certain things, like controlling abnormal bleeding and stabilizing the lining of the uterus. Nowadays, we use what's called bioidentical progesterone. That means formulations that are more similar to what our body produces. And we don't have the big randomized controlled trials like we do from the WHI, but we have lots and lots of data, studies that have looked at 85,000 women, suggesting that these formulations are more breast neutral and may not increase breast risk. And if you look at studies since the WHI, the risk of breast cancer is largely confined to studies using combination estrogen with a synthetic progestin. And studies with bioidentical progesterone are thought to be more breast neutral. We need studies, though, with these current formulations of hormones to really know for sure if it is indeed fully safe for the breast, because we do not know that for sure, but we know that bioidentical forms are more breast neutral than synthetics. The other things that we learned since the Women's Health Initiative is the reason they didn't see cardiovascular protection is the average age of patients in the Women's Health Initiative was 63, but the average age of menopause is 51. And most often, women coming in talking to their providers about initiating hormones are more often in their 40s and 50s and less often 60 and beyond. And in the Women's Health Initiative, who were within 10 years of menopause or under age 60, hormones actually did prevent heart disease. And that has led to now what's called the timing hypothesis, which says the risks and benefits of hormones differ depending on the age of the patient and years since menopause. And if you start hormones under age 60 or within 10 years of menopause, the benefits are thought to outweigh the risks, and specifically as it pertains to cardiovascular disease. Now, no large guiding organization in the US has currently come out and made a public statement saying younger women should take hormones to prevent heart disease. They all say the same thing is, if you're going to use hormones, you should use it for treating all the symptoms of menopause, preventing bone loss. And oh, by the way, if you do happen to start it in the right time of life, it does seem to prevent heart disease. My hope is that we are going to get statements that change and say it should be used for cardiovascular protection in young women. But the fallout from that study, so you know, the number of people, most women in the perimenopause and menopause are good candidates for the use of hormone therapy. And the current data I've seen is just under 5% of women across the US choose to use hormones when they go through menopause.
Wow.
Yeah.
under
So
that.
I have a couple questions of people that might think like I'm thinking, but when you say the progesterone, bioidentical progesterone, so like when you get a prescription, like I take progesterone and I get it at a pharmacy, what am I getting? I wouldn't even know.
Great question. So you are getting bioidentical formulations. I think people confuse the term compounded bioidentical and bioidentical. Again, bioidentical formulations of hormones exist and are covered by commercial insurance. You can go to your pharmacy down the street and you can get bioidentical estradiol and progesterone. That is typically what is given in current formulations of hormone therapy now.
Okay.
That term gets confused with what's called compounded bioidentical, which are formulations of hormones that are often combined in different ways and use combinations of different types of hormones. And those, they are touted to be safer because they are bioidentical and compounded and made in ways that support you as an individual. But we have no data to say that compounded formulations of estrogens are any safer than current formulations that have been studied in larger trials. And in fact, large guiding organizations like the American Endocrine Society, for example, have put out position statements saying if people want to use compounded formulations of hormones, that is fine, but we do not necessarily have enough guidance to assure safety, purity, efficacy of those formulations. And you need to ensure that those compounding pharmacies are complying with all of the regulatory requirements to ensure that you know what's in that product is really in that product. And so they cannot say that a compounded form of estrogen that contains E2, E3, all these different formulations of estrogen is safer than you going to the pharmacy and getting a prescription of estradiol. But that's where the confusion comes in. People think bioidentical means I have to go to a specialized compounding pharmacy to make a formulation of hormones that is specific for me as an individual.
That is great. So the thing that you're talking about with the estrogen and the patches and the estradiols and all of that, right now there's a shortage on patches, like at certain doses, because I'm on a low dose and it's hard for me to get it. It's like I have to call 3 weeks before I really need it to make sure it's going to come when I want it to. But then you gave the thing that only 5% of women right now, is, if I'm correct, are even considering or on HRT therapy. What is the problem?
I'm so glad you asked that. So the most recent data was less than 5%. That is changing. And the reason that is changing is the FDA removed the black box warning on hormones. So the fear that women have had, so after the WHI came out, the FDA slapped a black box warning on all formulations of estrogens, including even vaginal estrogens, that talked about the potential risks of heart disease and the risks of cancer, specifically breast cancer. And it was that fear that has kept women from utilizing hormones. It took a long time. The FDA has been petitioned for a long time to remove that black box warning. Finally, over time, they have gotten experts that came to them, presented data. It all came to a culmination this last year when they reviewed all of this literature. They had these experts in the space come to them and present evidence, and they made the decision to remove that black box warning. And that has opened things up. More and more women are going to be starting. The next time we start looking at how many women are using it, I expect we're going to see marked increases. But so the demand is increasing, and the pharmaceutical industry has not been able to keep up with that demand. And I don't see where that's going to be stopping anytime soon.
No, I'm a little skeptical with pharmaceuticals because there's not a lot of money in these anymore, right? Because they've been out so long. So
Yeah,
if you follow the money trail of it,
for all of these.
right. So the production of it is, they're not making a lot of money on that. So that's my little bit of skepticism coming out. So I think is going to be a while. If you look
You know
back
what?
to,
I will add though, because I'm a cup half full kind of person, why
Yeah.
we're even talking about menopause,
that's
part
true.
of this conversation has been changing because of us as women ourselves. We are pushing the conversation and pushing the dialogue, and it is
Yes.
changing from us. And so it is up to us to push. in whatever ways we can to help sure that production keeps up so women can get this. So that's my
100 that
thought.
thank you for that that's an important reframe, especially when you go back to looking at before Women's Health Initiative, 40% of women were on
Exactly.
HRT.
Exactly.
So we have a long ways to go just to even get back to even that level. So
But I have a question about that. When the women were on hormone replacement therapy back, in the early 2000s, was it the same as what we're getting now, or was it very different?
Great question. So on the whole, people were getting oral estrogens that were synthetic. One thing that has changed over these past many years is we have learned that hormones are not all the same, and they differ depending on the hormone, the formulation, how they're made. And nowadays, when we use hormones, we tend to use first line non-oral formulations. We tend to use patches. And the reason for that is there are studies that show when you use a non-oral formulation, you bypass what's called first metabolism through the liver. The hormones are absorbed through the skin, and when you bypass metabolism through the liver, you affect clotting profiles less. And there have been studies that show transdermal formulations of estrogens do not increase the risk of blood clots. And if you look at the Women's Health Initiative, one of the things they did find was a higher incidence of blood clots. So we tend to use nowadays non-oral formulations first line, and we tend to use these bioidentical formulations of estrogen. One interesting thing is in the Women's Health Initiative, they used what's called oral conjugated equine estrogen. The trade name was Premarin. That's the formulation of estrogen that in long-term follow-up has been shown to decrease breast cancer risk. What we do not know yet is bioidentical estradiol that we now prescribe in patch formulations as protective for the breast as oral conjugated equine estrogen? That we don't know. I want to see studies done, and I'm actually hoping at MIDI, because we actually have launched a whole MIDI Research Institute, and we are now the largest national provider of women's health care. We are seeing 30,000 women a week. Currently, I am hoping that we can help do some of the studies, that we can establish registry data to start following women to help answer some of these unanswered questions. So to answer your question, we are using very different formulations. On the progestogen side, so a progestogen is a term that covers any type of these progestogens that protect the lining of the uterus. There are synthetic progestins and there are bioidentical progesterone, and those are all formulations of what are called progestogens. In the Women's Health Initiative and what was used in the days prior to the WHI were synthetic progestins. Those drugs, again, very good they're very strong. They affect the lining of the uterus in a way that helps stabilize it. They are better at controlling abnormal bleeding, but those are the formulations that are also thought to have the negative effects on the breast. And as I said in the beginning, bioidentical progesterone, which is what is utilized now in current formulations of hormone therapy, are thought to be more breast neutral. So we are using different formulations. We still use those in certain situations. I think the key is you need to individualize. There are some people where a patch isn't going to be right. You have lots of skin sensitivities. You've got bad eczema. An oral form may be appropriate for you. So you need to individualize based on what someone's own health history is, their personal desires, and coming up with the right formulation. But in general, we have many formulations that are available now that we didn't have in the pre-WHI days.
talk to me for a minute about progesterone if you don't have a uterus.
Always get asked that, and I'm really glad you asked that. So again, estrogen in general is the component of hormones that tends to make you feel well. So if you don't have a uterus and you are choosing to take hormones, typically you're going to start with estrogen alone. There are studies that have been done in menopausal women that have shown that bioidentical progesterone in the form of this drug called prometrium has been shown to improve sleep. And so there are women, if they've had a hysterectomy and we start them on estrogen, and it alleviates many of their symptoms, but they are still having sleep difficulties, we may layer in progesterone. And in the trials that looked at sleep, it's actually higher doses of progesterone that are typically used in women taking it every day. So it does not always have to be a part of hormone therapy in women who've had a hysterectomy, but in some situations it may get layered on. Again, where I will caution people who are coming in saying, though, I want to use it for sleep. We do think bioidentical progesterone is more breast neutral, but again, we do not have these large randomized controlled trials telling us that for sure, that it is completely breast neutral. And in fact, in these big meta-analyses and systematic reviews, they showed that at least up to 5 years, there does not seem to be a higher risk of breast cancer. After about 8 years, possible increased risk. So I just tell people when they are just saying, well, give me both formulations of hormones. If you've had a hysterectomy, my own personal bias is to start on estrogen alone and then see how someone does. I do the same with testosterone. We haven't yet talked about that, but a lot of people,
That was my next question. That was the exact next question.
yeah, a lot of people ask, should testosterone routinely be a part of menopausal hormone therapy? And I think that also should be individualized. A few things about testosterone. One is it is not FDA approved for women. And one of the main reasons it's not FDA approved for women is there were trials that were done looking at a testosterone patch that actually had shown improvements in libido, so low sex drive in postmenopausal women who are on hormone therapy. They found improvements in low libido. They tried to get this patch FDA approved, but these trials came out on the heels of the WHI, and the FDA said, well, we want to see more safety data with regards to any type of hormone, and we're not approving that. And to this day, testosterone has never been FDA approved for women. So when I talked about compounding pharmacies are one of the ways to get testosterone for women, because the two ways that women can take testosterone are either 1/10 of a male hormone dosing or a compounded formulation. And the problem with using 1/10 of a male hormone dosing is getting it from a pharmacy, because testosterone is a steroidal hormone. And because of all of the doping issues around hormones in general, testosterone has been put on a controlled substance list. So it is a controlled substance. It is controlled by the DEA, the Drug Enforcement Agency. DEA regulations differ depending on every state in this country. But if you get a DEA controlled substance, you are supposed to have at a minimum of face-to-face visit every 3 months. For a woman to use a male hormone, a male version of testosterone, one of the common formulation comes in a box where the pharmacist would have to break open a box to only give a woman a 3-month supply to be in compliance with DEA regulations, and they may or may not do that. So a compounded formulation is one of the ways for women to get testosterone, but you need to make sure these compounding pharmacies are in compliance with all of the regulatory requirements, and they are doing all the appropriate testing to ensure purity and efficacy of their products. That being said,
But what are you seeing truly in the data? Because women have testosterone, right?
yes,
And just like any hormone, it's going to decrease over time, just like it does in men. I mean, I'm waiting for the conversations to happen for estrogen and progesterone in men. And when should they be going? But we're not talking about them today. But I do want to ask you, are you seeing women who are having remarkable results with hormone replacement therapy, obviously, but specifically with testosterone?
yes, but when you say remarkable results, I think we need to qualify what are they using it for. So to answer your
Fair.
question, women
That's a
have
fair,
testosterone. Our ovaries put out testosterone. Those levels do change over time. Our adrenal glands put out DHEA, which is a precursor to male hormones. So we do produce male hormones. When you look at the data, looking at the use of testosterone in women, the best evidence is for improving low libido in postmenopausal women. So there have been large expert consensus groups that got together, really good article that was published in 2018 looking at the evidence for testosterone in women, and no one will argue that there is good evidence for improving libido in postmenopausal women. Where things are changing is people have wondered, well, what about it for premenopausal women? I would say we do not have good evidence for improving low libido in premenopausal women, but many women choose to use it. We have FDA-approved drugs for low libido in premenopausal women. Flibanserin, the trade name is Addyi, and then another drug, Vyleesi, bremelanotide, the trade name is Vyleesi. Those are FDA-approved drugs for low libido. Both are FDA-approved in premenopausal women. Flibanserin, it just got FDA approved in postmenopausal women. But people are extrapolating the sexual functioning data to premenopausal women. We don't have that. And where people are really interested in now are for other things: bone health, muscle mass, cognition, fatigue, and overall well-being. We have better data in men than women when it comes to bone health and muscle mass. We are starting to look at data and seeing beneficial effects on things like bone density, but the evidence is not there yet for all of those areas from large randomized controlled trials. Are there some small trials showing a benefit? Absolutely. Do we need more trials looking at those specific areas? Absolutely. When women come in to see us at MIDI, we will say to them, the best evidence we have for the use of testosterone is improving low libido in postmenopausal women. If you are interested in it for any of these other reasons, you're a perimenopausal or premenopausal woman, or you want to use it for maintaining your bone health or muscle mass, we'll tell you what we know, what we don't know, but we are willing to offer it. So I would say we are seeing really good results when it comes to sexual functioning. And I don't think we have long enough data to see, are we going to see significant improvements? I'm particularly interested in the muscle mass and bone health.
Yes.
We know that muscle mass declines after menopause. We see the risk of sarcopenia or low muscle mass goes up. It's really important for women to be doing weight bearing and resistance training after menopause. And so I am particularly interested in seeing some of the long-term data looking specifically at muscle mass, bone health, fracture data on utilizing testosterone in women.
And to add
Excellent.
to that for postmenopausal women, are you also learning more and more about the GLP-1 helping for women at that age point too? Not necessarily for weight loss, but in a much smaller doses to help with other things. Is that something that you're seeing more and more of?
So at MIDI, we do have a whole weight management program. So we prescribe GLPs as part of a larger weight management program. So we are collecting data on patients using these weight loss drugs. I would say there is no other category of drugs that has had and seems to be having such a dramatic impact on medicine as these class of drugs. Separate from weight loss, lower incidence of cardiovascular disease, separate from weight loss. We have protocols where we are using it for alcohol reduction, for drug addiction, data looking at it. So the mechanism by which these drugs are thought to work is by lowering cellular inflammation, in addition to all the things that it does with decreasing food noise. But obviously they were designed as drugs for diabetes and obesity. And so we're seeing lower risks of diabetes, and after menopause, diabetes goes up. So we are learning more and more about the metabolic changes that happen with menopause. We see more increased weight, but you see weight distributed in very specific ways, more central adiposity, which is a risk factor for cardiovascular disease. And we're seeing, again, separate from weight loss, these drugs have an impact there. I mentioned before, ASCO, the American Society of Clinical Oncology, they just presented a multitude of studies looking at GLPs and cancer. Again, these are not randomized controlled trials. We need more studies to really determine if this is true, but they saw lower incidence of breast cancers, colon cancer, liver cancer, lower progression of cancer, less metastatic disease. Amazing results. It's being looked at for cognitive loss and things like Parkinson's, kidney disease, liver disease. The studies we specifically did at MIDI were fascinating. I will clarify that these are not just looking at GLPs, but it was part of our broader treatment. But we looked at women who came in with elevated LDLs above 160. So typically those people are going to be treated with statins. We have protocols to start people on statins, but some of those people are going to be on statins alone, statins with hormones, GLPs alone, GLPs with statins or with hormones. And we found within 6 months, people had to have had 3 visits with us from 2023 and 2 lab draws at least 6 months apart. And we saw an average 30-point drop in LDLs. And we saw for women who came in with prediabetes that 60% during that same time frame normalized their prediabetes and dropped their hemoglobin A1C into a normal range. Some of that is a result of GLPs. We are now trying to do a deeper dive because what I really want to understand is how much is an independent effect of hormones or hormones with GLPs or hormones and metformin. And so all these different combinations to really do a deeper dive and understand that. But I do think, and to your question about what about lower doses, that's an area where we are learning. Most of the data when we are looking at outcomes currently is based on standard dosing that is used in people who are using GLPs for obesity. What we don't yet is have long-term data on the beneficial effects, presuming there are beneficial effects of microdosing. Microdosing essentially means providing someone with a dose that's right for them, which may be lower. So if you have, let's say, prediabetes and elevated lipids, but you really don't need to lose much weight, just a little bit, you may choose to do a lower dose. Or what happens when you achieve your weight goals? You need to be on some lower dose to maintain that, but is that once every 2 weeks, 3 weeks? Is it the lowest dose once every 3, 4 weeks? I think we're still defining what does microdosing mean and still defining what are the health benefits that we will see from microdosing. I don't want your listeners to take away that every single person in this country should be on GLPs. I think there's still a lot we are learning, but they are very, very interesting class of drugs that are having huge impacts. And I think we're just going to be learning more and more about them.
I'm interested because I'm in the category you're talking about. And it was recommended to me that I do that. I don't need to lose weight per se. I mean, everyone needs to lose 5, 6 pounds, whatever. That's not why. And she had suggested it to me and I'm like, I don't know. I got to think about that. So
I will tell you, I'm exactly with you. And I am not promoting what I do for my own self, but I am currently microdosing to try and see if it will help with my prediabetes and borderline or increasing lipids.
Yeah, I have the same problem. Okay, that's good to know.
Again, I don't want to promote it for me as right for everyone else, but I am curious to see what happens.
But that is perfectly leading into what I was just going to say and what is so refreshing about your approach and MIDI's approach. You are a scientist. You write by heart and by nature.
I'm an academic person by heart, and I'm trying to bring that back to MIDI too. Yeah.
Yes, but also you have worked with patients. You have had a robust practice in every aspect of your life. You've bettered the ball, to use my favorite sports analogies, right? I think about my now 40-year-old daughter who at 38 was starting to have what really appeared to be hormonal problems. And I, as a mom of 3 daughters, the one thing that I can give them is pushing them to keep looking at this, that it really is affecting you earlier than you think it is. And she went to her OBGYN and said, I'm starting to have these things. And he said, you're too young. And my response was, you need a new doctor. And unfortunately, there's still a lot of that that's happening in the world, right? But what MIDI is doing is it's giving access to women to be able to ask these questions. And what you said was so refreshing, Dr. Goldman. You said, we will give you all this data and tell you what we know, and then help you if you choose to go that path. You're not going to do anything that's illegal, but you're going to listen, and you're going to take each independent person's story and build what should work for them. And it might be trial and error, and it's not going to happen overnight, but you are working with them. And that is beautiful.
I would tell you that part of the reason we have grown as quickly as we have is women are telling us they are being heard. And that is our goal, to listen to them and individualize care and help them make choices that are right for them. I will tell you what has been incredibly personally satisfying. I am a better doctor since I joined MIDI, and I've been in practice for 30 years. And I am a better doctor because I know so much more primary care that has allowed me to be more holistic in my counseling, whether it's counseling to our providers. We have lots of ways that we provide support to our clinicians at MIDI, or whether it's when I'm seeing a patient. We are becoming at MIDI more of a midlife hub, a hub for midlife women, and we cross cover many aspects of primary care and women's health, realizing that there's a gap in people able to see their OB-GYNs. 50% of counties in the US don't have an OB-GYN, but we also know that it can take months to get into a primary care. And so we are providing care in the areas that you can safely provide over telehealth. And in doing that, we have developed protocols for all of these many areas. And I realized I had a patient of mine come in not too long ago who really wanted a discussion about could she use hormones after having had breast cancer years ago, but she had also had a heart attack. And in the past, I would have said, I need to send you to a cardiologist to talk about the heart attack. And I was able to talk through all of the literature about the use of hormones in people with established cardiovascular disease. And I feel like I am a better provider. We also have people at MIDI that have integrative care, naturopathic care, expertise. And so in all of our protocols for care, not only do we discuss standard hormones, non-hormonal pharmacologic options, but every one of our protocols also goes into evidence about integrative therapies, supplements, herbs, botanicals, where it exists and where it doesn't exist. We have patients come in every day saying, I've read about this. Is there evidence behind it? We look whether there is evidence behind that, and we incorporate these things into our protocols very quickly. And that has just allowed, I think, all of us who are at MIDI to feel like we are so much more holistic in the way that we can provide care.
It goes back to what you learned very early on from Marina's care when you talked about Western medicine and adding in, and now the expansion. It's truly an explosion of care, which is such a beautiful reframing of it, and really incredible. And so,
And
now,
let me just add one thing, if you don't mind.
not at all.
In order to democratize this kind of care, you have to be insurance covered care. And what I am really proud of is we are in all 50 states and covered by insurance. We are trying very hard to expand our insurance. My hope is that one day we will be on every type of insurance so we can really ensure that we can democratize this kind of care for every woman across the country.
How about for Medicare patients?
We're working towards it and hoping that within the next year, hopefully early in 27, we will be on Medicare. We have a number of patients that are seeing us that are going to age into Medicare and want to know. We do have whether they can continue seeing us as insurance covered care. We have a small percent of our patients, 90% see us insurance covered care. We do have a cash pay option. We are not concierge. It is $250 for initial visit and $150 for all subsequent follow-ups. That still is out of reach for some people, but it is not concierge level. That we are hoping for people that we are not covered, that may at least provide an option if they can't find insurance covered care elsewhere.
And to follow up to that too, I think that's the important thing to talk about, really to touch on, is at 67, and Lisa's now 65, we are both using HRT. And I don't have any plans to stop anytime soon. I don't know about Lisa, but
No, well, it's
And I-
interesting you're saying this because I was going to ask her a question. So you go with yours and then I'm going to do a follow-up question.
so my question is, number one, do we have to quit if we're seeing the benefits? Obviously, if we're being followed with our normal care and all of that. But also, I am a person, because of I was off of it for a while, and then I'm sure I went through menopause. I don't have a uterus. So at some point in there, I went through menopause, right? And I don't exactly know when the exact time or the date was. And I'm positive that when I went back onto HRT, it was 10 years post. So what does that all mean for me?
So there's two questions you asked me in there. One, if
Of
I'm on
course.
hormones, do I have to stop based on age alone? And what about, can I initiate hormones if I am past that so-called timing hypothesis window? So for your
Right.
first question, the answer is no, you do not have to stop based on age alone. And in fact, the large guiding organizations in this country, the Menopause Society, American College of OBGYN, all changed their public statements somewhere around 2017, stating that there is no reason that people need to stop based on age alone, but they need to be seen exactly like you said, regularly, to make sure that you aren't developing any health issues where taking hormones might not be the right thing. You had a stroke, you had a heart attack, you've developed hormone-positive breast cancer. But if you are a healthy person, there is no reason to stop based on age alone. The question about starting past that timing hypothesis window is really an interesting one, and I will tell you how we have thought about it at MIDI, which is not necessarily consistent with how every provider across the country may think about this. So the main reason why this timing hypothesis window exists is as hormones pertain to cardiovascular disease. And estrogen is thought to change coronary vessels in a way that make them less sticky, and platelets and all of the factors that form plaques or coronary artery disease don't form if you start someone on estrogen early. If you start someone after they have been menopausal for many years, the thought is they already have plaques in their coronary vessels. And when you actually start someone on hormones and they have plaques in their vessels, they can even destabilize those plaques initially. And so, in fact, if women use hormones post heart attack, which occurred due to coronary artery disease, in those first few months after a heart attack, hormones can increase the risk of another cardiovascular event. Well, we have many ways of assessing people for cardiovascular disease. There are known risk factors. There are things that you can calculate, an ASCVD risk, MACE. The American Heart Association just put out something called Prevent to try and prevent heart disease. And these are all risk calculators where you put in people's blood sugars and or their hemoglobin A1C and their lipids and their age. These are heavily age-based or heavily age-biased. The risk of heart disease goes up with age. But one of the things that, like the MACE includes, is something called a CT calcium score. And it's a type of CAT scan that looks at your coronary vessels. It can't tell all types of plaques, but it is a very good indicator if you have coronary artery disease. So let's say you are in your 60s, you are more than 10 years from your last menstrual period, you don't have diabetes, your lipids are good, you're normal weight, you don't smoke, you're healthy, and you get a calcium score and it comes back 0. We would say, you know what? You may be a good candidate for starting hormones, even though you're past the timing hypothesis window. What we can't tell you, however, is will hormones prevent you from getting cardiovascular disease? We know for women who started early on that it does seem preventative. We don't yet have any data to say for people who initiate it post 10 years who are good candidates based on all of risk modeling, will they get cardiovascular disease prevention? And the other whole area is, will they get cognitive prevention? We do not know that. We know a lot more about heart health than we do about cognitive disease and cognitive health. We are learning that there is likely a timing hypothesis for the effects of hormones and cognition as well. But the answer is we individualize. So there are many people at MIDI that we will choose to start hormones who are well past the timing hypothesis window. Again, remember that the risks of heart disease increase with age. So it is very uncommon, for example, if a woman comes in and they are 70, 75, that we will initiate hormones because when you do those models, because they are heavily biased towards age, the likelihood is that they are going to have some degree of risk for cardiovascular disease. But we always individualize. And so I think the good thing for your listeners to hear is no longer an age-defining spot. It's determined by your own personal health history. And I would almost say that you need to counsel people that the risks and benefits differ depending on how far from menopause, but there should no longer be an absolute age initiation defining spot as well.
So that's good to hear. I mean, coming from a personal place, right? So I did have my calcium score. I was very proud that it was a 0. It was a funny story because I had my daughter look at my chart because I said, "Oh, I'm going in for triple bypass. Just tell me what it is." Like it was kind of a joke, and it came back 0. But I have those other things, right? A little bit elevated here, there, whatever. And I did start hormone replacement therapy a year ago.
You're in the same boat as me.
Okay, so all right, I'm glad to know you're doing the same. But anyway, what has made the biggest difference for me is my mental, like my cognition, my brain fog, my energy, all of that has drastically changed for me. And for me, I mean, I say it's like a drug. It's like if I can't get my patches, I'm like completely freaked out. But I noticed the biggest difference, right? I can feel it. It took about 6 months. And so then I say to myself, okay, well, I'm well past the 10 years. And, is it going to be safe for me to continue this? Like, I don't know the answer. I'm not asking you to answer, but I think there's a lot of women in my same place, or you're in the same place,
Exactly.
and what do we say, like, I am not their doctor. I am not their therapist. But again, what I do for a living, everyone thinks I do all of that. They'd like me to probably give them a facial if I could. But what I'm trying to say is I think that's a big question for a lot of people out there. Where do they start? Like what resources? Of course, MIDI, I send them to MIDI. I send everyone, joinmidi.com. Just go there, do it. But
what we are trying to do through MIDI is help educate patients. And we have the ability, medicine is not stagnant. So to answer your question is, I think people need to be seeking out care from people who are staying on top of the literature in this space, because we are going to start learning the answers to those questions. Like I said, you have noticed a change in your cognition, in your mental health, your brain fog. That's an area that I think we are still learning a lot about, which is how do hormones impact our cognitive health. But you need to be seeing someone who is focused in this area. I don't fault primary cares who can't keep up with this. There's an awful lot to keep up with in medicine, but you should be seeing an expert in menopausal care, whether that's someone in your community or see us at MIDI. and ask us those questions. I think women are the ones that started this whole movement of saying, I deserve better care. I want to know, can I take hormones? And I do want people to hear there are still categories of people that shouldn't take hormones, but no one should feel that they have to suffer at this time of life. We should always be able to come up with treatment options, and there are very effective non-hormonal treatment options for many of the symptoms of perimenopause and menopause as well. So I would say women need to be advocates for themselves. And if you aren't getting the care or you aren't getting your questions answered by your clinicians, your physicians, your nurse practitioner, whomever you are seeing, seek care out elsewhere. Use us as a resource. Hopefully people will come to see us for care, but we also put out blogs. We have lots of social posts. We have lots of a newsletter we put out that provides information on so many of these areas that people want to know, like, can I continue on hormones? Can I start later? So seek out care from experts in this space. Don't accept, we don't know, but be an advocate for yourself.
I think that's so important. Social media is flooded, right? Social media is flooded with information. Where are the right places to go? If someone were to ask you for 3 sources that you would trust the most, where would you send them? Besides MIDI, of course.
It's a great question. I say it's a great question partly because I think nowadays we all need to do a deeper dive. So if I hear something on social media or I go to an AI tool, whether I'm talking of Chat or Gemini or Claude, I will double check. I will do additional searches, whether that's going to PubMed. I will do my due diligence to make sure if I heard something on social media that is referenced by a reputable journal, it is referenced in other materials, it's not one person giving their opinion. I think you can get good information from societies like the Menopause Society, American College of OBGYN. I think the problem with some of the societies is it takes a while for them to change what they are doing and come out and make a public statement. So at MIDI, we are able to evolve in a little bit quicker fashion. And so we will adopt things like choosing to do shared decision making about starting hormones in someone past the 10-year window before some of these big societies may make a public statement about that. I think that there are now a lot of sites that people can use, whether that is up to date, open evidence. Open evidence is really designed is for people in medicine. I think you can get now when you do various AI searches, they will give you references. Look at the references. Don't just take something for granted. But I would say either come to a place like MIDI, go to a society, a national society like American College of OBGYN, the Menopause Society. I do think you can get good information off of social media, and I do think you can get good information off of search tools. I just think you need to double check what you're hearing to make sure that it is fully accurate and you are understanding the sources of where that information came from.
Absolutely. Lisa, you had a question about working out.
Oh, my workout, I will gladly go through. I work out every day, but my regimen has changed since I did like you. I chose to go back on hormones after more than 10 years. I find the same thing that you do. My brain is sharper. But so my hormone regimen has changed. My exercise regimen is about the same or increased. And I'm also microdosing. So all of that, my own regimen has changed. But
This
happy
just
to
makes
share.
us love you even more because you are willing to change and put your money where your mouth is, so to
Totally.
speak.
I want to understand this. So, and yeah.
Amazing. Bravo.
I'm
People
sorry
want
because I
more.
know we could have gotten to
No.
more if I shortened my answers.
No, it's okay. Mindy, it's good. You are awesome.
Thank you,
Okay.
Mindy.
Yeah, happy to come back. Okay.
We will catch you again. Thank you. Okay, I need a moment to just take in all that we took in.
Yeah, that was good. That was really good. It was fantastic information. It was very valuable. It was very interesting, Katie, to understand the behind the scenes of MIDI, that when you make your appointment with MIDI, you don't realize all the things they're doing behind the scenes to give you the answers they're going to give you. And I think that was very eye-opening for me.
I think it is too. But what I really, really appreciate about her is that while she works within the scientific or the academic mindset, she's also pushing for the correct information out there. Because guess what? While women are waiting for the scientific and academic, they're losing years. We've seen the last 20 years be lost for a whole lot of women who haven't had this available to them because of improper information. So I think
Right.
that's where MIDI comes about, Dr. Mindy Goldman comes about, and so many others that are working in this space and really bringing things to light. We learned about the fact that MIDI has gone into a partnership with her self-health. So we want to do more looking and research on that. MIDI is doing so much. They've founded Age Well. So that's something that we need to look into. So there is more to have people back to talk about. And I'm just so happy we've been able to do this. And if people want more information on MIDI Health, it is joinmidi.com, M-I-D-I, joinmidi.com. Is
And
that
I will say
organization?
that I have told so many friends, family, and clients about this organization. I have used them myself. I'm actually going to go back to using them. And I can't say enough good things about them. The one thing that I didn't have a chance to tell her or ask her was the one thing that I think is the hardest to do with MIDI is if you're not technically savvy like me, getting all that information to them and how to download all that information can be challenging for someone like a person like me. So if you are challenged with technology, get someone to sit next to you. Get someone to sit next to you that will say, Lisa, just do this. Lisa, just do this. And then it will work. Yeah. So, but that was my only little tiny negative experience. But I'm like that with a lot of technology, not just applying at MIDI.
I was going to say there's a level of patience that goes into something like this when you're not getting it right off the bat. Okay.
But yeah, and this was a great podcast. She said she'll come back. So anybody who's listened to this podcast and has questions, please send them in because then we can ask them and when we have her back.
We absolutely can. And any more information, as we talked a little bit about at the beginning, we are streamlining our podcast a little bit. We're going to have less banter at the beginning, a little more banter at the end. In this case, I am exhausted.
You're exhausted? I'm not. I'm
Having
like
to-
energized. I'm like the energized bunny.
It's so much information. And actually, it was nice to get some very specific answers to questions that we've had for quite some time. One of the things that I think is really important, and you said too, feedback, any questions you have for us, you can reach us on theviewinyourmirror.com, and we always appreciate that. So how fortunate are we to continue to have people that say yes to us, like Dr. Mindy joining us on this podcast so that we can give this kind of information, which may be one of the most important podcasts we've ever done, this one right here.
I agree with you 100%.
And in order for this to continue to happen, we have incredible sponsors we want to thank. And we talk about Rustica all the time. I want to touch on Sweet Ivy. Just every time I go in there, it's such a joy. And we really thank them. They are located in the Galleria and have just an incredible store full of really wonderful clothing that you can have a lot of fun with.
And accessories. And you can see everything online now.
And shoes. Oh my gosh. Let's even the
Yes,
shoes.
I just bought a pair myself. this week.
Yes. Yes. And I know that you have been in more recently than I have to Beam Light Therapy.
Yes, I have, Katie. It was
And-
great.
And we do have a special going with Beam Light Therapy. You can find that on our website, theviewinyourmirror.com. And I know that Mindy did talk about girlsinc.org as her organization for her nonprofit. And we ran out of time to do that because we pushed her right up against her next meeting. So we didn't get that in. But look up girlsinc.org and really helping young women learn to navigate life and all life has to throw at them. And lastly, I want to say this. We talk about it all the time about how important your personal view is in your mirror, but your view is worth fighting for, and it's worth advocating for yourself in order to maintain that view in your mirror. Today really felt like a good time learning that it's important to fight, right? So go to your doctors who listen. And if you cannot find that doctor, MIDI Health is where you want to go. And in the meantime, put that smile on your face, throw your shoulders back. Know you are working to be the best version of yourself you can possibly be. Until next time.